Emily Scott is a 64-year-old female stockbroker who was in her normal state of health until 2 days ago, and today she presents to the ER with upper belly pain that is not like her. Pertinent active medical conditions include hypertension for the past 10 years that is well controlled. 3 days ago, Miss Scott was served divorce papers, and later that night she ended up going out to the bars and had multiple drinks. She noted that the pain started the next day after her alcohol consumption. The pain began in her epigastric region and radiated to her left upper quadrant as well as to her back. She describes the pain as deep, steady, and sharp, as well as a burning pain. She said the pain started as a 3 out of 10 and has rapidly progressed to an 8 out of 10. The pain has been consistent and progressive over the past 2 days. She has tried Advil, 2 pills, 200 milligrams every 12 hours in order to help make her pain better, but to no relief, as well as 3 Tums, a one-time dose that she said took her pain from an 8 out of 10 down to a 6 out of 10. She notes that the timing of this occurred after consuming the alcohol. The patient has no prior workup for similar symptoms. Past medical history includes hypertension for the past 10 years, which she is taking lisinopril 20 milligrams once a day for and is well controlled, in addition to the Advil and Tums that she's taking for her stomach pain currently. Patient has no known drug allergies or allergies to latex, as well as no pertinent family history. Pertinent social history includes recently divorced and living alone, and the patient notes that she consumes about 4 to 6 alcoholic beverages per day, and she realizes and acknowledged that this was a problem. The patient also has a 60-pack year history and denies any recent travel or any sick contacts. Pertinent review of systems, the patient denies straining or difficulty with her bowel movements, but did note that her bowel movements were floating in the toilet. She denies any recent skin changes, chills, fatigue, or lethargy. General survey, the patient presented alert and orient times 3. She was dressed appropriately, odorless, well-groomed, and appeared her state and age. The patient appeared to no signs of respiratory distress, but did appear to be lying on her side with her hips and knees tucked up to her chest in order to what appeared to be alleviating her abdominal pain. Gait was not able to be assessed over telehealth. Vitals include BP of 140 over 88, respiratory rate of 18, temp of 100.8, heart rate of 110 beats per minute. Abnormal physical exam findings include tenderness to palpation in the epigastric region as well as the left upper quadrant. Normal exam findings, there was no scars, pulsations, peristalsis, bulging, or ascites noted in her abdominal region. Bowel signs were present in all 4 quadrants. Her abdomen was soft and non-tender to percussion and palpation in the other 3 quadrants. She had a negative Murphy sign as well as no CVA tenderness. When it comes down to her differential, the top differential diagnosis includes acute pancreatitis, which is believed because of her pain associated with her alcohol consumption. And peptic ulcer is the second differential diagnosis, which is less likely because she noted that she used to have GERD-like symptoms with eating spicy foods, but she's eliminated that from her diet, which makes this diagnosis less likely because her diet is more controlled now. And the third differential diagnosis is cholecystitis, which is because of her epigastric pain as well as her floaty stools, but because the patient has no signs of jaundice or history of stones, this diagnosis is less likely. As well as with pancreatitis, which is the first and most likely diagnosis, that is more likely because of the epigastric pain that is radiating towards the back, which is a normal finding with that. Diagnostic and testing includes, we should be ordering amylase and lipase labs, a urinalysis, CMP, LFTs, and BUN. Also, we're going to be ordering a fasted lipid panel at her next appointment. No imaging is currently required. To manage this patient, we should refer her to the ER and have her have IV access for fluid management and as well as oral fluid restriction and make the patient NPO. When the patient's discharged, we'll discharge her with PO NSAIDs. We should also be managing her electrolytes while in the hospital. As well as education goes for the patient. We need to educate her on her chronic alcohol use and try to get her to limit that because that could be exacerbating her symptoms, whether that be getting her into meetings or encouraging proper social support. As well as we need to be encouraging her cessation from smoking, and we could write her a prescription for varenicline for that, as well as her noted depression that we should be acknowledging and making sure that she has a strong support system at home. We should see the patient. She'd be in the hospital for about 5 to 7 days, and we should follow up with the patient in about 1 week.